So as rightly titled, we ophthalmologists have an important role in giving the right glass prescription to children and frame their future. So in the next 10 to 15 minutes, I would be discussing about the general guidelines of prescription in children, how and when to individualize, and with few examples. So why is it challenging in children? It's because children are unable to cooperate and give a proper, reliable response. And there is most of the time need for cycloplegia and frequent visits. And most importantly, the dread of amblyopia. So before prescribing, we need to know a good history from the parents, more often otherwise a reliable source. And also we should look at the behavior of the child, like whether the child is visually engaging, whether there is lack of attention span, and also the socioeconomic background of the family. So all this is important before prescribing. Also, as we know, cycloplegic retinoscopy is a gold standard. And we also need to do a basic squint evaluation, like a cover test for distance in near, and check the ocular movements before prescribing. Role of fogging in children, maybe in little older children who can give a subjective response, especially in cases of hyperopia. And post-mydriatic test in situations where the pre and post cycloplegic retinoscopic values don't match and there's any discrepancy. So cycloplegic refraction has to be done ideally in all patients, but an atropine refraction, I would say, is must in esotropia, especially in younger children less than 5 years of age, and before planning on surgery, and as well as children who present with accommodative spasm and pseudomyopia. So these are the basic principles. As we know, emmetropization occurs usually around 3 to 6 years of age. The eye is usually hyperopic at birth, and it is the hyperopic defocus which causes axial elongation. So when we look at the refractive status, we have to see whether the refractive status is normal for that particular age of the child. And if left untreated, whether that refractive status will emmetropize over time. So usually in these situations, then we observe, we don't have to prescribe. Whereas if the refractive error or the refractive status of the child is going to disrupt the normal visual development and can cause amblyopia, so these are situations when we have to prescribe glasses. And when we prescribe, we need to see if our prescription is going to improve the visual function. And at the same time, whether the prescription is going to interfere with emmetropization. So these are the basic principles, and we can understand these with some examples. So this is the AIO guidelines from 2023 to 2024, the latest edition. So as we can see here, the cutoff is usually lower for hyperopia and astigmatism because they are more amblyogenic, and especially when there is associated strabismus and anisometropia. And for Indian standards, actually, the cutoff is even lower. So these are the AIOS guidelines. So these are all based on clinical experience. So first, let us go to hyperopia, which is actually the gray zone. It's the gray zone because we actually don't know sometimes how much to undercorrect or prescribe in hyperopia, because undercorrection in hyperopia can actually affect binocularity when there is associated esotropia. And sometimes overcorrection, the child will not tolerate, and overcorrection sometimes or full correction can affect emmetropization. So if we see the presentation, usually untreated hyperopes usually present with esotropia when the hyperopia is moderate, that is around 2.5 to 5 diopter. Because in these situations, the child will have a tendency to accommodate to see clearly, and then there will be esotropia. Whereas those kids with high hyperopes, usually how much ever they make an accommodative effort, they will not be able to see clearly, and usually they present with emmetropic amblyopia. So in such an example, like in a 5-year-old with esotropia of 35 to 40 prisms for distance and near, if this is the degree of cyclorefraction, then we'll have to prescribe the full cycloplegic refraction. So any degree of esotropia, we need to prescribe the full correction, even if it is as low as 1.5 diopters. So these patients have then to be followed up with the glasses, and we'll have to look at the alignment. So in this example, if you see, a 4-year-old has been prescribed glasses for hyperopia with esotropia. And with the glasses in the follow-up visit, the child is still having 25 PDET for near and 8 prisms for distance. So here again, we'll have to look at the AC by ratio. So the AC by ratio here is more than 5. So this kid will then need bifocals, executive bifocals. So whereas in another situation, if the distance and near esotropia are equally large after the full correction, then that is a partially accommodative esotropia, where we'll have to plan a surgical correction for the partially accommodative component. Whereas when there is no esotropia, we have to prescribe usually if the hypertropia is more than 4 or 5 PD. Usually less than 4 diopters, the child will overcome with ease. Whereas if it's more than 4, there can be astigmatic symptoms. But in these children, you can undercorrect up to around 1 to 1.5 diopters, or even up sometimes 2 diopters. Again, weaning, yeah, the age is still controversial. Usually we can start around 8 years of age. Weaning, if at all done, has to be done gradually in steps, not to affect the vision or the squint. So in hyperopia, so these are the main factors that we should consider before prescription. Usually the presence of esotropia, anisometropia, amblyopia. And yes, in special children, usually they also need plus glasses because of lack of accommodation. And sometimes children don't tolerate moderate to high plus prescriptions in the very first visit. So these children, you can give a cycloplegic course for 2 weeks so that they will accept the glasses better. And especially with plus glasses, parents have to be counseled the need for glasses in these children. So most of them, they will be able to manage without glasses also, but parents have to be counseled clearly regarding the need for glasses. So now moving to myopia. So here is an example, like in a 4-year-old with a myopia of 2.75 and 3-3, yes, we need to prescribe. But if it's the same in a 2-year-old, maybe we can still watch and see. Because in myopia, again, there is no role for undercorrection or overcorrection. Undercorrection can actually cause myopia progression, and overcorrection can cause astigmatic symptoms. And always cycloplegic myopes to avoid any overcorrections. So over minus therapy is only advocated in intermittent exotropia, because in intermittent exotropia, we want the child to accommodate and improve convergence. So over minus therapy is advocated only in intermittent exotropia. So in myopia, again, a presence of intermittent exotropia matters, where we can give some over minus. And other than that, history of prematurity, history of laser for ROP, all this is important. And in high myopes, we'll have to ask for history of photophobia, night blindness, and look for nystagmus. And nowadays, we need to spend a lot of chat time with parents for myopia and discuss them the myopia precautions, even from the pre-myopic stage, and discuss about the control measures in myopia progression. So moving to astigmatism. So here is a case of a 4-year-old with a cylinder of -4 diopter and -3.5 in both the eyes. So this prescription, again, yes, it is mandatory. Otherwise, the child can go for amblyopia. So with astigmatism, actually, no amount of accommodation is going to correct the astigmatism. So again, there is no role for undercorrection here. And oblique astigmatism, the risk of amblyopia is more. And usually the cylinder is less than 1.5 diopter. In a school-going age, maybe we can still watch and treat only if the child is astigmatic. So with astigmatism, the factors that matter are the type of astigmatism, again, anisometropia and amblyopia. And these patients can usually have allergic conjunctivitis. And we should also look for any associated ptosis or lid swelling. And most importantly, we'll have to identify keratoconus suspects and follow them up. So whenever there is anisometropia or amblyopia, we have to give the full correction, and there is no second thought about it. And in the presence of anisometropia, the cutoff for hyperopia is 1 diopter, astigmatism is 1.5, and myopia is 3 diopters. And these prescriptions have to be prescribed, like given as early as 3 years of age, because even at that age, this degree of anisometropia can cause amblyopia. And in the presence of anisometropia and amblyopia, again, counseling of parents is very important because compliance is an issue, and we'll have to follow them up for amblyopia. So we'll just then discuss about management of aphakia and pseudophakia. So usually with regard to aphakia in children, in less than 3 years, unifocal can be given by adding +1 to +3 diopters to the distance correction. And bifocals can be started after 3 years of age. And but in aphakia, we should remember that we'll have to prescribe as early as possible. So even on day 1 is still fine, but as early as possible. And managing unilateral effects is a big challenge. Yeah. So contact lens, if feasible, would be a better option in these cases, especially in toddlers or infants with poor spectacle compliance. And rigorous amblyopia therapy is again needed in these situations. So with regard to aphakia in children, most of them, they need repeated refractions, sometimes examination under anesthesia. And we should also watch for myopic shift in these children. And the secondary IOL can be planned at maybe 4 years of age. And again, pseudophakia, we can prescribe around 2 to 4 weeks of time and give the full correction, which we get on a dilated retinoscopy. And any tight sutures, yeah, that has to be removed. So bifocals again in children, apart from this high AC by ratio, we need to give bifocals in those with lenticular disorders like ectopia lentis, where the accommodation is going to be poor. And again, children with developmental delay or CVI, again, will have lag of accommodation. So they may also need bifocals. Prisms, yes, have specific indications in strabismus. And in nystagmus, when there is an AHP, we can add prisms. And those children with field abnormalities, yoke prisms may be used. And severe convergence insufficiency, both exercising and relieving prisms can be used. So generally, the follow-up of children after a glass prescription in a regular case is usually around 6 months. But when there is associated squint, EZO or EXO, then we call them a little earlier, like around 2 to 3 months of time to see how the alignment is with the glasses. And if it's a first prescription, then usually we can wait for a refractive adaptation period of around 12 weeks when there is significant anisometropia or amblyopia. And on follow-up, again, we'll have to watch for compliance. Sometimes reasons like boring frames or colors can also be the reason for poor compliance. And also we should inspect the glasses, check the centration of glasses, especially in high cylinders. Even a small difference in centration can cause discomfort to the child and maybe reason for poor compliance. So a word about dispensing. So pediatric glass is actually not a miniature of adult. And again, there are many factors with regard to dispensing of glasses in children. More importantly, in less than 4 years, when the nasal bridge is not properly developed, flexible frames are advisable, and preferably with a lower crest, a large frontal angle, and a larger splay. And with regard to materials, it's usually CR39. Polycarbonate is for those children with poor vision. And again, tints may be advised in children with albinism and aniridia. And the role of blue protect lenses is not well established in children. So the final take home is the period of infancy to early childhood is very crucial. And we should know that in the initial few years, the child's interest is going to be of the near world. So the factors that are very important are age, emmetropization, the visual needs of the child, the degree of refractive error, presence of strabismus, anisometropia, and amblyopia. So all these factors have to be considered before prescribing. And usually, if it's an appropriate prescription, the child will tolerate. And most important part is to counsel the parents and convince them. So prescribing glasses is actually an art that develops with experience, and we should prescribe not just to improve the visual acuity, but also to improve the visual functions and the performance. Thank you.